I recently did a hormone therapy 101 class, and oh my goodness, the questions were popping off. So I didn't have time to get to all of them, and I'm going to pick the 9 most common because of all the questions that came in, of course, a lot of them overlapped. I'm going to pick the 9 most common and go over them here with you today. So these are your questions asked to me about hormone therapy. Let me tell you the 9 questions, and then I'll go through them one by one. So I was asked, what is the difference between synthetic progestin and a progesterone, and what is micronized progesterone? That's one question. If someone's intolerant to peanuts, should they still take prometrium? Are they even a candidate for progesterone? Is the topical progesterone sufficient to prevent uterine hyperplasia? And what's the max dose somebody would need for this? In perimenopause, can progesterone 200 milligrams be taken daily, or can I cycle it? Are patches considered estradiol, or are they synthetic? Should a woman take her patch off when she gets her period? Can you talk to the DHEA vaginal and when you should use that over the estrogen vaginal? Can I do progesterone if I have a Mirena in? I also use estradiol. And I'm on blood pressure medication and I check my blood pressure at home. Is having hypertension an absolute contraindication for taking HRT and or estrogen in any form, whether orally or transdermally? All right. If you want to know the answer to any of these 9 questions, then keep listening because I got you. Let's go through them. Number 1, what is the difference between synthetic progestin and progesterone? So progesterone is what we consider natural body or bioidentical. Progesterone is what your actual ovaries would make if you ovulated. The synthetic progestins are close, but they are not exactly identical, and they do come with extra risks that progesterone doesn't seem to come with. Now, it's important we distinguish between the two, a progestin and a progesterone, because in research papers, sometimes in education, they will confuse the two words. I was recently reading a research paper, a 2025 research paper overview of HRT out of Korea, and they called it synthetic progestin, natural progestin. That was new for me. I've never heard that. We don't have a natural progestin. Progesterone, and then the umbrella term is progestogen. So that's the difference between the two. Progesterone is progesterone is progesterone. Now, the next part of her question is, what is micronized progesterone? Progesterone as a molecule is big and it's hard to absorb, especially when you swallow it. So what they do is they micronize it. And when it's micronized, then it absorbs a little bit better. So you will see OMP, oral micronized progesterone. For example, if you use prometrium, which you can get a prescription for at any pharmacy, prometrium is OMP, oral micronized progesterone. If you get your progesterone compounded, then you will probably see on there that it says OMP, oral micronized progesterone. Basically, it's just micronized so you can absorb it better when you swallow it. Number 2, if someone is intolerant to peanuts, should they still take prometrium? Are they otherwise a candidate for progesterone at all? The answer is no. If you're intolerant to peanuts, you shouldn't take prometrium. Prometrium does have peanut oil in it. Full disclosure, prometrium also has some filler and it has some food dye. So if you are also food dye sensitive, you should probably be aware, or at least look at the kind of prometrium that you're getting, read the handout, or talk to your pharmacist. But having a peanut allergy doesn't mean your progesterone days are over. You can actually get progesterone compounded without any peanut oil. And it's a really great reason that we have compounding pharmacies for situations like this. Other than prometrium, we don't have any other progesterone available at your typical regular pharmacy that can be prescribed. But we can use regular old oral micronized progesterone, just like the kind in prometrium, and it can be made at a compounding pharmacy without food dye, without peanut oil, like without, anything that you might be allergic to. So that's what I do for my peanut intolerant or full-on peanut allergy people. And that's why we have compounding pharmacies. And just in case you're curious, a compounding pharmacy is a pharmacy with a pharmacist, and they actually just make the medication for you. Some pharmacies are a combination of a typical pharmacy. They'll fulfill your pharmaceutical, your blood pressure med, or they'll, whatever you need from your pain med or your migraine med or whatever you use, your SSRI, they can fill that. And then they have a whole separate section where they can actually make medication specifically for you. So that's where we use compounding if you have a peanut allergy and you would like to use progesterone. So you can still use progesterone. We just go a different route. Number 3, Is topical progesterone sufficient enough to prevent uterine hyperplasia while on estradiol? Now, if you still have a uterus and you're on estrogen, estradiol, which is E2, then we have to protect you against the thickening of the inside of your uterus. This is called hyperplasia. Worst case scenario, hyperplasia can progress on into uterine cancer or endometrial cancer, and we don't want that. So what we use are usually oral progesterone that you swallow. Or even a progestin, that's okay too. We use the progestin IUD to protect. We use vaginal progesterone. Those are the things that have kind of been deemed anti-hyperplasia. Topical progesterone that you rub on your arm or rub on your thighs hasn't been shown to reduce the risk of hyperplasia. So that's not usually the one anyone goes for, because we can't show that it gets the progesterone levels high enough. It gets to the uterus and it protects against hyperplasia. So there's a pretty good reason if you're wondering, like, well, why didn't my prescriber give me just the topical cream? You can get it over the counter. You can get it at a natural health food store. You can get it all over the place. It's because of that reason. It doesn't seem to protect against hyperplasia in the research studies. So we don't tend to use that. If you don't have a uterus, you've had a hysterectomy, your uterus has been removed, and you like topical progesterone. Let's say in your early perimenopausal years, you've been using topical progesterone, you rub it in your arms, and you're like, I actually feel really good when I use this form, and you don't have a uterus, I don't have to worry about hyperplasia. Then I'm like, if you were my patient, I'd be like, well, girl, keep on. Like, if you like the topical and you don't have a uterus, I'm not that worried. If you do have a uterus, though, then I'm worried. If you're not on estrogen, let's say you're listening to this, you're using topical progesterone, you rub it in your arm, and you're like, oh no, am I going to get hyperplasia? If you're not on estrogen, I don't have to worry about that either. So if you're using topical progesterone, you love it, you love how you feel, you're not yet on estrogen, or you don't want to go on estrogen, you're just cruising with your topical progesterone, cool, sweet, stay on it. That's fine. The only issue is if you have a uterus, you're on estrogen, hasn't been shown to be protective against hyperplasia. So then we'd have to switch or do some sort of combination to help keep you feeling good, but protect against that one thing. Okay, number 4, in perimenopause, can progesterone 200 milligrams be taken daily, or does it have to be cycled? So the answer is it can be taken daily or it can be cycled, but it depends on you, your goals, and what your prescribing provider says for you. Since I don't know who wrote this question or who submitted this question, I don't know their case, but in some cases, some women are at the point where they love it every day, and other women cycle it. And by cycle it, I mean they still get their period. So they get their period, that's day 1. They don't use progesterone the first 14 days, and then they'll use progesterone the second 14 days until their next period. Or, they kind of divide it in half and however long your cycle is. If your cycle's a little shorter, then you may, start a little sooner, day 12, day 11, and then stop when you get your period. Some other providers will say, actually, I start people on, don't do it on your period. So go 7 days, no progesterone. And then I start on day like 8. So I have seen, again, your goals, what's going on with you, what you need. I have seen providers cycle it different ways. And I've also seen women love progesterone and do it continuously. I've seen women ramp up and ramp down. So they'll do like 100 in the second half. So like day 14, they'll do 100, day 15, they'll do 100, day 16, they'll do 100. And then day 17, they'll do 200, day 18, 200. So you like kind of ramp up and then ramp back down again, similar to how the body does it. I've seen all sorts of ways, depending, again, what your provider says, what your goals are, and where you are in perimenopause. So you have options. Number 5, are patches considered estradiol? So the estrogen-only patches are considered estradiol. Yes, and that's like the estrogen you make in your body. So some examples are like Climera or the Dottie or the Minivel or their generics. You probably have gotten their generics. Now, there are 2 patches that have a progestin in them. So Climera Pro, so Pro for progestin, and the combi patch, as in combination patch, and that's estradiol plus a progestin. So if your provider is prescribing for you an estrogen only patch, and you can ask them, you can clarify with them, you can ask the pharmacist, read the handout. If it's estrogen only, it is estradiol. And the other 2 cases, it will be a combination with a progestin on the patch. Some patches you change once a week, some patches you change twice a week. It depends on the person. It depends what works for you. In fact, I was talking to my own doctor the other day, and she said the once a week, she said, I'm noticing in my patients that by the time you get to the end of the week, after showering and exercising and changing clothes and applying lotion, it's like not really sticking anymore. She goes, I like the twice a week because it's easier to stick on. The adhesive stays on, just those couple of days, then you change it. And I was like, yeah, I'm hearing the same feedback. But absolutely, I have women that go, I can't remember to change it twice a week. I can barely remember, like what day of the week it is. And then they like the once a week. So just keep that in mind when you're thinking about your patch and what works for you. Number 6, should a woman take her patch off when she gets her period? Usually the answer is yes. Usually if you are on a patch, you're changing it twice a week, but you still get your periods, then usually most providers say like take it off when you get your period. You don't necessarily have to if you're on like a low dose patch, like 0.025, for example. But I would say if I asked most of my colleagues, they would say, yeah, if you get your period, stop your patch. Give yourself a break. Number 7, can you talk to the DHEA vaginal and when you would use that over the estrogen vaginal? So the estrogen vaginal, which is low dose vaginal estrogen, does go a little bit systemic, but it doesn't really raise the estrogen level systemically. It stays locally in the vulvovaginal area, like wherever you kind of apply it. Estradiol is really great for the microbiome in there. It's good for the tissues in there. And so for women that are having itching, burning, recurrent urinary tract infections, pain with sex, dryness, change in tissues, maybe the tissue's getting thinner, it's getting more irritated, it's shrinking, the labia can shrink. That's where estradiol really shines. And estrogen is usually done a couple times a week. So I have had women do like what we call a priming, like prime the pump. So you'll, depending how long you've been without estrogen, we may have you do a week or 2 with low dose vaginal estrogen. So every day, and then 1 to 3 times a week as needed. So you can kind of be the gauge of like, oh, I'm feeling a little dry today, I'm going to use estrogen. Now, remember, we don't necessarily want to use estrogen as lubrication. Your partner may not want that extra estrogen, but that's typically how we do the low dose vaginal estrogen. Where do we layer in DHEA? I am a huge fan of the vaginal DHEA. That one's a little bit more high maintenance in that it's generally recommended to do daily or almost every day. I really like DHEA because it too can convert eventually into estrogens. DHEA is considered like an upstream or a pro hormone. It can also turn into testosterone eventually. And so it can be really good for the strength of the muscles down there. I've talked to physical therapists, like pelvic floor physical therapists, who feel that DHEA vaginal helps improve tone, helps improve bladder control, helps improve maybe like mild prolapse. Coupled with physical pelvic floor physical therapy, like adding the DHEA can help just improve down there, help make sex less painful because the muscles are stronger. The pelvic bowl is a little bit stronger. So I have women that just do the low dose estrogen. I have women that do both. They love the combination. And I have women that are like, I feel more comfortable starting with DHEA. I'm not ready yet, I don't think, mentally for estrogen, even though it's a low dose. And they start with DHEA instead. So again, we can custom tailor this to what you need and what might work for you. Number 8, can I do progesterone with the Mirena? And the answer is yes. Now, this is going to surprise. I have a lot of conventional practitioners who don't know this, or they would say, like, why would you do that? The Mirena has a progestin in it. It's built in. Yes, and it's great for the uterus if you're using it for birth control reasons, heavy period reasons, or to prevent hyperplasia. But it doesn't have the relaxing, calming sleep effects that progesterone does if you were to take progesterone orally. So I absolutely have women that have the Mirena or the Skyla or the Kylena. There's other progestin IUDs out there, and they use it for birth control, or they use it for heavy periods, or they use it for whatever, fibroid management, or they use it to prevent hyperplasia. But they're like, Carrie, I'm not sleeping. Like, I'm not sleeping. I'm like, okay, let's try a little bit of oral progesterone with it. It's not contraindicated. It doesn't knock one out. It doesn't like cross react. That's not how it works. So you can do progesterone with the Mirena if you have a Mirena. Again, it's the oral progesterone for the sleep, calm, relaxing effect that it can have. So that progesterone will be taken at night. And lastly, number 9, I am on blood pressure medication and check my blood pressure at home, is having hypertension an absolute contraindication for taking HRT and or estrogen in any form? Controlled blood pressure, just like it sounds like hers is pretty well controlled, is not an absolute contraindication for hormone therapy. First of all, it's not an absolute contraindication for progesterone. For estrogen, we use the transdermal form. So again, you're well controlled, you're doing great, your doctor's proud of you, you're proud of you, you got your blood pressure down. Transdermal estradiol is the route they're going to go. So it's not an absolute contraindication. The oral estrogens that you swallow, whether it's Premarin, which is the synthetic estrogen, or it's actual estrogen, estradiol, we don't usually go that route because once you swallow it, that can increase the risk for cardiovascular things. And you already have a cardiovascular thing. You have high blood pressure, but it's controlled. If your blood pressure is not controlled, it's out of control, they're going to work on that first, most likely, before they say, okay, now let's do hormones. Again, they may start with progesterone and maybe risk benefit. You're actively working on your blood pressure and they may say, let's do a low dose of transdermal estrogen. Maybe they'll just do the vaginal estrogen depending on your symptoms. So by evaluating you as a whole around blood pressure, that's the most important part, but it is not an absolute contraindication in this case. And I understand, like, it used to be any blood pressure issues at all, it was an absolute. But now that we know with more research, you've got it under control, you're monitoring at home, that going on hormones, depending on the route and the type, is usually probably okay. Now, again, you're going to get monitored no matter what. You're getting monitored. So it's not going to be like you go on hormones and it's a free-for-all. It's pure chaos and loosey-goosey. It's not going to happen. Like, you're getting monitored, right? So make sure that your provider, understands this. It's not an absolute contraindication, and you keep right on top of your blood pressure. All right. I hope that was helpful. I know that you've got a lot of questions. I know hormones can feel like herding cats, and that's why I'm here to help. I'm here to help break this down, make it a lot more clear, especially when it comes to hormone therapy. If you're considering it, thinking about it, on it with questions, curious, I got you.